Thanks so much, Sarah and Tim, for the invitation. It's a real pleasure to be here with you today. So in the few minutes that I have, we're going to discuss the indications for aortic repair in Loeys-Dietz syndrome, describe some common surgical techniques for various parts of diseases in various parts of the aorta, and review the personalized approach to cardiovascular management in LDS. So we heard in a brilliant lecture this morning by Dr. Dietz and his description of this. We've learned a lot about LDS in the last 10 years, and patients with LDS can really vary in how severe their phenotypic presentation is, and as the guidelines suggest, right now, patients who have mutations in any of the LDS genes, along with documented aneurysms or dissections, may be considered to have Loeys-Dietz syndrome, including those with milder phenotypes. So these are, as the guidelines suggest, the surgical thresholds for intervention in Loeys-Dietz syndrome. And this is for LDS 1, 2, and 3. And the reason these numbers have been chosen is that patients with Loeys-Dietz syndrome have a more aggressive vascular and aortic phenotype than those without connective tissue abnormalities, or even those with Marfan syndrome. So for example, patients with aortic root aneurysms, the root is the portion of the aorta that's right above the aortic valve. It encompasses the aortic annulus, these coronary arteries that feed the heart muscle up to this line here, the sinotubular junction. So this is the most common area for aortic pathology in LDS. And our threshold in the general population is an aneurysm threshold of 5.5 centimeters. In Marfan syndrome, it's 5. And now for Loeys-Dietz syndrome, we intervene much earlier stage we consider aortic surgery at a threshold of 4 centimeters. And the reason for this is that particularly with families with aggressive histories of arterial aneurysm dissections and rupture, and those with more severe craniofacial abnormalities, we know that they can dissect and have catastrophic aortic complications at much earlier sizes, in less than 4 centimeters. So we intervene earlier. So, and this is why we like to intervene on an elective basis rather than during an aortic catastrophe. So even in the most experienced hands, patients who present with an acute type A dissection have a surgical mortality of 20%, whereas in experienced centers like Hopkins, in Toronto, in large tertiary care referral centers, patients having elective root surgery or elective hemiarch replacement, for example, have very low mortalities of less than 1%. So we like to fix our patients in this setting rather than in an emergency basis. So my take-home message to you today, though, is size matters, but size isn't everything. And we really try to adopt a personalized decision-making to patients with Loeys-Dietz and aortic aneurysms. So what kinds of things do we take into consideration when I see someone in my clinic with a connective tissue problem and aortic aneurysm? These are the types of things we think about. The absolute size is certainly an indication. The rate of expansion is very important. Some patients have very stable aortas that don't change in size for years, whereas others, including especially those who we hope with as medical treatment improves, we will have more of those patients, but others expand quickly. So expanding more than 0.5 centimeter per year in the root and ascending aorta, or more than 1 centimeter per year in the descending or abdominal aorta, those are concerning numbers to us, and if we saw that, we would intervene earlier. Patients who also have, for example, a very leaky aortic valve would prompt us to intervene earlier. A family history of aggressive disease, so a history in the family of patients rupturing or dissecting at earlier thresholds would certainly warrant for us an earlier intervention. And we balance all of those things with the risk of intervention. So an aortic root replacement in a experienced surgeon's hands is a low-risk operation, whereas a redo complex arch surgery or an extensive thoracoabdominal replacement is a high-risk procedure, even in experienced centers. So that's in the elective setting. What about urgent operations? So urgent indications include aortic rupture, rapid expansion, as we discussed. Patients with type A dissections, so dissections in the ascending aorta, all of those are surgical emergencies that must be dealt with immediately. Those with type B dissections, on the other hand, and I'll show you just some pictures so you understand what those are, we only operate on those with complicated type B dissections, meaning patients who have malperfusion, so lack of blood flow to the gut or spinal cord or kidneys, patients who have ongoing pain or hypertension with their type B dissection despite medical treatment, those with signs of impending rupture. So this is what we're talking about when we discuss dissections. So type A involves dissections that include the ascending aorta. And the reason these are surgical emergencies is because the risk of death with just medical treatment is extremely high, 1% per hour, 50% within 2 days of dying from a type A dissection. So we operate essentially on all of these patients. And the reason the risk is high is because the dissection can go backwards, disrupt the coronary arteries that are feeding the heart. It can cause the aortic valve to become severely leaking, and it can rupture within the chest. So these are surgical emergencies, and we treat them right away. Patients with type B dissections, on the other hand, do far better with medical treatment than with surgical treatment initially, and therefore we don't operate on them unless there are complications. Most patients with type B dissections are treated with blood pressure control and close monitoring, and certainly patients with connective tissue problems, Marfan syndrome or Loeys-Dietz, we would image very, very frequently initially, even within the same, the first few days after a type B dissection, and then very close CT scans to make sure that that aorta is stable. If it's rapidly expanding, we would consider an operation, but if it's stable, then those with type B dissection, so involving the, descending or entire descending and abdominal aorta, those we follow and operate on for the same indication as for an aneurysm. So just for size, we would follow and monitor for size, and it's not the dissection itself that prompts us to operate. So what about children? So I'm not a pediatric surgeon, but just a few principles. We try to delay surgery until the aortic annulus is above 2.2 centimeters. And the reason for that is we want the graft that we can implant to be able to accommodate the child as the child grows. For patients with milder phenotypes in the family or slowly progressing diameters, we could wait until adult threshold, so 4 centimeters, but those who are rapidly expanding or severe craniofacial features or an aggressive family history, we would consider earlier intervention. And this is, again, the take-home message. So we balance for each patient individually what is the risk of not doing an operation versus the risk of surgery. And when the risk of having an aortic complication is higher than the risk of surgery, that's when we operate. So I'm just going to touch briefly on a few common types of procedures. So this is an aortic root aneurysm in the proximal portion of the aorta. And Dr. David, Tyrone David, who is my mentor and now my partner at Toronto General Hospital, is the surgeon who invented this procedure, valve-sparing root replacement with a reimplantation technique. And he really changed the lives of patients with Marfan syndrome. Rather than requiring a mechanical valve and requiring lifelong blood thinners, patients who we see with aortic root aneurysms, if we open the aorta and the valve looks like this, so it's a normal appearing valve with 3 leaflets over here, a good amount of tissue, no big holes, the valve is not destroyed. Patients who have a valve that looks like this this can undergo the David procedure or reimplantation and have their own native aortic valve preserved, and we just fix the root aneurysm by reimplanting their own valve in a graft and then sewing on those coronary arteries back into the graft. Those who come later to us or during an acute dissection, or patients who have really large root aneurysms, by the time they come to us, often the valve leaflets are damaged, they have holes in them, and we're not able to save the valve, and they undergo what's called a Bentall procedure with a mechanical valve that's sewn onto a graft with, again, we put back in those coronary arteries. This is a durable operation. This mechanical valve lasts forever, but you do need to be on blood thinners for that. So what about further up the aorta, the aortic arch? So the issue with the aortic arch is that it's a critical part of the aorta that gives off these blood vessels to our brains and our arms. And we weren't able to do these operations for many years. This was essentially part of the aorta that we never approached because of the risk of stroke with these operations. But surgical techniques have improved dramatically. When arch surgery started in Houston in the DeBakey and Crawford era, the risk of stroke and dying from an arch replacement was 25% risk of stroke and 25% risk of death. And now the risk of even an extensive arch replacement in an experienced center in an experienced surgeon's hands is 5% death and stroke. So the numbers have improved significantly, and the reason for that is that we're able to instead of we used to cool patients down to 18 degrees and completely shut off the blood flow to the brain in order to sew these arteries back into our graft. Now we are able to give blood flow to the brain during the repair, so it's really changed things for us. One consideration that I do for patients with Loeys-Dietz or Marfan syndrome is, rather than implanting all of these arteries together in an island, we do individual bypasses like this to each of the arteries because of the risk of future dilatation of those patches. So, and then the last portion of the aorta that I'll discuss is the thoracoabdominal aorta. So the key thing over here is that this part of the aorta gives off blood vessels to the spinal cord. So the reason these operations are risky is because the more aorta that we replace, the higher the risk of paraplegia and death from the operation. And again, these types of surgeries, certainly for patients with Loeys-Dietz or connective tissue issues, but even for the general population, they're usually done in centers of excellence with high volume experience in this particular kind of operation. And again, you can see when we address the arteries to the gut and kidneys for patients with Loeys-Dietz, we would use these branches rather than putting in a whole patch of repair. Outcomes for an extensive type 2 thoracoabdominal operation, basically replacing the entire aorta from the left subclavian artery down to where the aorta bifurcates to the legs. The outcomes have improved a lot also in this kind of operation, and they're now, the risk of death is in the range of 5 to 10% if this is done electively. If it's done as an emergency, it's very, very, very high risk of death. So patients ask me, what about stent grafts? And for patients with connective tissue considerations, we do not recommend TVAR or stent grafting. And the reason for that is that when you're putting in a stent, you have to sit it in normal aorta and normal aorta. But patients with Loeys-Dietz syndrome do not have normal aorta. And so the stent, when it's sitting in an aorta and that aorta continues to grow, then that stent becomes unstable. It starts floating in the breeze and you get late endo leaks and the stent fails essentially. So we do not recommend it as the primary course of treatment, but it can be used as a life-saving measure in patients who have an acute emergency of this part of the aorta. And then in other situations where there's graft above, there's been surgery before, there's graft above, there's graft below, then in that situation where we're putting the stent in between two pieces of graft, then we could consider stenting. So just a few pictures. This is a type A dissection. It's not a Loeys-Dietz patient, but this is what it looks like. This is the false lumen over here and the true lumen over there and the torn aorta. This is why we need to survey people after type A dissections. This patient's had a type A dissection. This portion of the aorta has been repaired, but you can see the tear continues over here, and there's an aneurysm forming in the proximal descending thoracic aorta. And this is a patient of mine who has Loeys-Dietz syndrome that Dr. Bradley called me about urgently last year. This patient had a type A dissection 3 years previously, had a mechanical Bentall. You can see the ascending aorta's been replaced. It's normal. The arch has a dissection over here. That's that line. And he was lost to follow-up. He did not have any imaging for 3 years and came with a giant 7-centimeter aneurysm in the proximal descending thoracic aorta. And we, fixed him urgently. He went home in a week, and we'll continue to follow the rest of the aorta. And that's one of the most important things that I tell my patients is when we do these operations in a controlled fashion, the outcomes are great, and we can really change the length of life of patients with aortic pathology because of that. So close follow-up and monitoring, as Dr. Bradley will speak to you about in the next talk, is crucial. So in summary, we do have lower surgical thresholds for Loeys-Dietz syndrome. Prophylactic or preventative surgery is preferred to emergencies. Early consultation with expert surgeons is recommended. The risk of, and we balance always the risk of aortic complications versus the risk of surgery, and personalized decision making is the key. Thank you very much.